Did I talk about acute severe asthma?
No, sir. So you just the line went off when the moment we got there.
Oh wow.
So
I've been okay. I've been talking to the airport.
Oh,
okay. All
right.
Okay.
Sorry.
That's fine. All right. Okay. So clinical features. So what I was saying was, so there's tachypnea, which means that the respiratory rates will go up. Then usually there's the use of accessory muscles, so intercostals, subcostals, and all that. And then the classic part is what you hear when you listen to the chest. You put a stethoscope there and you hear a whistling sound. Okay. So once you put it there, you hear a certain, you hear that classic sound when you have a patient who has an acute asthmatic attack. Okay, so once the patient comes to you, difficulty in breathing, you look at intercostal muscles, you have an intercostal muscle recession, you look at subcostal muscles, there's some subcostal recession over there. The abdominal muscles will be employed in breathing as well. And then you go like, all right, okay, you have a respiratory distress. Listen to your chest, then there's a rhonchi. You can go ahead and say, all right, patient has an asthmatic attack. And I said that when you have an asthmatic attack, it can go two ways if it doesn't resolve, okay, during your management. So if you are treating an asthmatic attack and it's past 24 hours and the patient still has bronchi, then you say the patient has an acute severe asthma, okay? In this case, the asthma fails to resolve within 24 hours. So the patient is there, you're trying to communicate with the patient, you realize that the patient is unable to complete sentences. So when this starts, the patient will find it difficult to complete sentences, okay? Then apart from that, you'd also realize that the respiratory rate of the patient is gone up. Okay, so a patient will be doing a respiratory rate greater than 30. Once you have a new patient doing a respiratory rate greater than 30, you say, okay, this is not just acute asthma, but acute severe asthma. Then the patient's pulse rate will go up 110 beats per minute or more. When you see this, you shouldn't be in a haste to say, oh, I'm going to give a beta blocker because the pulse is high. The reason why the pulse is high is a compensatory mechanism. Okay. So if you go and you give something of this sort, a beta blocker, then you are going to kill your patient. Then there's a peak expiratory flow rate, and this peak expiratory flow rate is a mechanism or a certain procedure we do to assess the amount of air you are able to expire. So there's a device which looks like like a marker. It looks like the size of a marker, but you are able to blow through this device. Ideally, if you find yourself in developed settings, every child who has asthma would have his or her peak expiratory flow rate checked. We check your peak expiratory flow rate and record it in your history. In case you come to the hospital with an acute attack and we assess your peak expiratory flow rate and we are doing 50% of your usual peak expiratory flow rates, then we can say that, okay, this is an acute severe asthma. So in a place where you haven't recorded the person's original peak expiratory flow rates, you will not be able to assess severity using this technique, okay? But in any ways, once your treatment or your asthma fails to resolve in 24 hours of treatment, you start thinking of acute severe asthma. In worst case scenario, you can develop a life-threatening asthma. And the life-threatening asthma, unlike the usual asthmatic attack or acute severe asthma where you listen to the chest and you hear sounds, in this case, you don't hear any sound at all. And that is what we call a silent chest. The chest becomes totally silent, okay? You don't hear anything at all. Then you realize that the patient, because the patient is having difficulty in breathing and poor oxygenation of tissues, the patient will develop cyanosis. And then Patient will be tired. This pulse rate, which was initially high, would drop. It's like your patient is going into a morbid or a mortality state, okay, because the patient's activity drops, pulse drops, you don't hear any sound. Your peak expiratory flow rate here will be less than 30% of the normal. There's something called pulsus paradoxus, which if you are able to measure will give you an indication. You would usually, when you check the blood pressure, you realize that when a person, during the inspiration stage, when a person breathes in and you check your blood pressure, your systolic blood pressure will drop more than 10 millimeters of mercury of the person's usual systolic blood pressure. And that's what we call pulsus paradoxus. Pulsus paradoxus is a drop in systolic pressure of more than 10 millimeters of mercury during inspiration. Okay, certain conditions that give you pulsus paradoxus, apart from severe acute asthma, pericardial effusion, cardiac tamponade, and all that, that would also give you a pulsus paradoxus. Investigations, as I said, we don't investigate a patient to say you're asthmatic. Asthma is a case of clinical diagnosis. So you listen to the history, you examine, you listen to the chest, you hear a rhonchi, and you say this is asthma. Okay. The investigations here would come in when you would want to do something, a supportive something. A patient has asthma and is coughing, and the cough is coming with phlegms and all that. You want to pick up the organism causing the cough, because the organism here is the trigger. So you would want to do a sputum for culture and microscopy and all that. Okay. It's good to do a full blood count. If you have an asthmatic patient coming to you with an increased body temperature, you would want to look out for neutrophils. Chest x-ray is also very, very essential here. Then there's something that we sometimes do to the patient comes and then tells you, oh, doctor, sometimes I have difficulty in breathing. I think I've got asthma and all that, but the patient didn't come to you with symptoms. What is sometimes done is the healthcare professional tries to trigger symptoms in the patient and assess to see if it is indeed asthma. If it's asthma, you will react to certain things. So they can expose you to histamine, and histamine will cause a reaction. Of course, mast cell produces histamine, so it will cause a reaction. Okay. If indeed you are asthmatic and we expose you to histamine, then we will expect you to have bronchoconstriction and mucus production in your bronchus, and hence difficulty in breathing. So we do that, and then we say, all right, okay, you're asthmatic. So it's called histamine bronchial provocation test. Okay. Another substance called methacholine can also be used to provocate your bronchial space. And then if you're asthmatic, you're going to have a bronchoconstriction, lots of secretion being produced. It's the same thing goes for exercise test. You let a person exercise for some time. If the person is asthmatic, this might trigger the asthmatic reaction, and you go like, okay, you're asthmatic. But apart from that, it's basically a diagnosis of, on clinical grounds. You take a history, you examine, and then you make your diagnosis. The management of asthma is pretty much straightforward. Okay, so your non-pharmacological management is always necessary to advise the patient on his or her condition and the need for the patient to try and stay away from triggers, not to use strong scented perfumes and all that. It's very, very important. Patient uses a woolen carpet at home, has to take it out and all that. Then when it comes to the acute management, this is important because you'll be getting a lot of patients and they'll be coming at very weird times. You've gone for a night shift, you are trying to sleep, and then the asthmatic patient comes. You should know what to do as soon as they come. Okay. So, the classic thing we do is to say we'll nebulize. So nebulization is very, very, very vital when it comes to asthma. It's even important than giving the intranasal oxygen. The reason why they are put intranasal oxygen there is usually when you're in the emergency room, your intranasal oxygen is always ready. But when your patient comes to you with asthma and the patient can't breathe, it's actually not polite to you leave the patient there whilst you are mixing your salbutamol and things, and the patient is still having difficulty in breathing. So sometimes, for what is worth, you just connect the patient to the oxygen whilst you mix your salbutamol or your terbutaline in the nebulizer. Mind you, if the airway is really, really restricted, the oxygen you are giving won't go. So you don't waste time. As soon as your nebulizer is ready with your salbutamol, you quickly put it on and then you let it go. Okay. The nebulization, what we do is you give 5 milligrams. This adult medicine. In pediatric medicine, it's a lower dose. But in adult medicine, we give 5 milligrams, 30 minutes apart, and you're going to give 3 doses. Okay. Sometimes people just give 1 dose and listen to the chest. There's no Ronchi, and then you say, okay, the asthma is gone, go home. As soon as the patient sits in the car and is headed home, patients will get another trigger. So usually for asthmatic patients, we should be very, very careful. There are 2 groups of patients that I'm very careful when I'm sending home: asthmatic patients and sickle cell patients. If you are not careful, you end up losing the patient. I remember there was one private hospital I used to work. We were managing this man for asthma and all that. It was an admission for, I think, a whole day. And then the next day he said he was fine. He wants to go. I mean, you listen to the chest. The chest was fine. There was actually no Ronchi. But as soon as the man descended from the staircase, he didn't even exit from the hospital. He just had breathlessness, had a cardiac arrest, and then he died on the spot. So sometimes some of these things, we need to be very, very careful before you discharge your patient. Okay. So you give your salbutamol. For me, if I give you first cycle, second cycle in 30 minutes, and then I listen and there's no Ronchi, I'll still insist that you wait till I give you your third cycle. And even after the third cycle, I'll let you wait for about 30 minutes before I reassess. I'm saying this because ideally, if possible, every patient coming to you with acute asthma, you should give the patient a bed, nebulize, and let the patient be there for like 6 to 12 hours and be assessing the patient. But sometimes some patients will come to you at the OPD and they'll tell you they get this every time, but their Ventolin is finished. That's why they come to the hospital for nebulization. You nebulize 1, 2, and say, oh, doctor, I'm fine. I want to go home. You have a lot of patients giving you that pressure, or parents giving you pressure that discharge their kids. Ideally, if you nebulize and the chest is clear, it's good to keep for like 6 to 12 hours and be listening to the chest, ideally. But if not, you always have to document that patients insist on being discharged, always, so that you don't get into trouble. So you give, normal is to give 3 cycles, 30 minutes apart. And then if you think the patient has got an infection that needs admission, or after the 3 cycles, you are still not okay with the patient, you admit for 24 hours. Okay, and during these 24 hours, you are going to give your salbutamol every 6 hourly. You are going to give salbutamol 5 milligrams. So in 24 hours, you are giving 4 times. Sometimes we give every 4 hourly. So in 24 hours, you are giving 6 times. So you can say that in 24 hours, once you admit, you are giving about 4 to 6 times 5 milligrams of salbutamol. Okay. And most of the time, if your first 3 doses of salbutamol doesn't work, and you want to do a 24-hour dose, it's good to combine with something else like ipratropium. So ipratropium bromide comes at 0.5 milligrams or 500 micrograms. So you are going to give that one like 6 to 8 hourly for 24 hours. Okay. So sometimes for me, what I do is I spread my time so that I know I'm giving ipratropium 6 to 8 hourly and salbutamol 4 to 6 hourly. So if I start giving my salbutamol at 8 a.m., I'm expecting that after 4 to 6 hourly, so maybe 12 to 2, I'll be giving another salbutamol. Okay. So in between that 8 a.m. and then the 12 to 2, I'll give ipratropium in between. So that I can say, okay, I'm giving my ipratropium like 10 a.m. or 10 to 12 a.m. So then you can see that, all right, so 8 a.m., you give salbutamol, you're expecting to give the next dose. Let's say if you are doing 6 hourly, you're expecting to give the next dose at 2 p.m. What can I do between the 8 and then the 2 p.m.? Let me put the ipratropium there. So I'll start my ipratropium in between. So I'll start my ipratropium at 10, and then I'll give my next dose of ipratropium after 6 to 8 hourly. So when you do it that way, you realize that between every 2 to 4 hours, either you are giving salbutamol or ipratropium. You understand? But when you give all at the same time, then it means you become restricted. You might have a prolonged period of 4 to 6 hours where you are not giving anything at all. So it's always good to try and then put it in between. Okay. So you give your ipratropium, and when the patient comes to you, for me, what I do is once I start my nebulization, I'm looking for a vein to set a line for the patient. Okay. Because the next thing you do after your nebulization, or whilst your nebulization is going on, is to give IV hydrocortisone. Usually for adult medicine, we give 200 milligrams start. If it so happens that you have to admit a person for 24 hours, then you do 100 milligrams 6 to 8 hourly. Okay, so that is what you do in the acute phase. And then when you are discharging your patient, you discharge your patient on prednisolone. Okay, so usually they say 4 to 60 milligrams daily for 7 days. I like doing a low dose, so maybe 40 milligrams, then I taper off. So first 2 days I'll do 40, second 2 days I'll do 30, then the third 2 days I'll do 10, and the last day I do 5. It's always good to taper off, because if you don't taper off and you keep giving high doses of prednisolone throughout and you stop abruptly at the 7th day, you are going to have some sort of adrenal insufficiency, in that the prednisolone you are giving will stimulate your body to stop making steroids. So when you stop abruptly, your patient is going to have steroid deficiency, which is also not good. But when you gradually reduce it, your patient is going to sense that, all right, okay, it's going down. Let me start making some steroids to meet it. So by the time you get to your 5 milligram, which is 1 tablet, your body has regained its ability to make steroids. So that's how you give steroids. And when you are discharging, you discharge on the steroids. If there's an infection, you would want to discharge on antibiotics. Usually, the common causes of infections for upper respiratory tract infection will be your gram-positive. So your strep, pneumonia, and all that. So you give a gram-positive antibiotic like the penicillin. So amoxiclav will be okay. If you are thinking this could be an atypical organism, you give your azithromycin. So what I do is I discharge them on prednisolone and then combine amoxiclav with Zithromax for them. Okay, so I've managed the infection, I've put them on a steroid, and then I'll let them go home on an inhaler. There are 2 types of inhalers. You have what we call the reliever and then what we call the preventer. Reliever here works like how they come and we nebulize them and give them salbutamol. Relievers like Ventolin contain salbutamol. So when the patient gets an asthmatic attack, before the patient comes to you, they can pump the reliever and then they come to you. When your asthma is bad or you realize you are using your reliever so many times, you quickly have to go to the hospital for assessment. Okay. Sometimes people use the inhaler and then they are fine and then they stay home. You'll get another attack. So you use your reliever and then you go to the hospital. A preventer usually prevents the asthmatic attack from starting. So when you look at the last slide, there's a combination of steroids and then beta-2 agonists. So you have fluticasone and salmeterol, which is called Seretide, and budesonide and formoterol, which is called Symbicort. Okay, these are preventers. The steroid in there would prevent an asthmatic attack from even happening, because the steroid is an anti-inflammatory. So when depending on the drug and the dose, you usually take 1 morning, 1 evening, or once daily. Once you inhale that, you realize that you're not getting asthmatic attack. We usually give it to patients who have uncontrolled asthma, who are always getting asthmatic attacks every day. We'll put you on a preventer. which you'll be taking every single day. Okay. Let's say you've given your salbutamol nebulization, ipratropium, IV hydrocort, and the patient is still having an asthmatic attack. In severe cases, we would start the patient on IV aminophylline. IV aminophylline has a bronchodilatory effect. So we put the patient on that. And what happens is once you give your IV aminophylline, it's going to open the airways. Okay. So you usually put about 250 milligrams into 500 mils of normal saline or DNS, and you let it run for about 6 hours, and then you check the chest again. Then you repeat another one. You do that for like 24 hours, okay, for the patient. So there's a role for IV aminophylline as well. Any questions before we move on to the next?
Sir,
yes.
Please, in the precipitating factors, you mentioned allergen and environmental factors.
Yeah.
Yeah. Initially, I was thinking that anything that triggers the asthma is allergen. But with this one, it seems like the allergens are different. So what is the difference between the allergens and then the environmental factors?
Okay, so when you look at it, okay, the allergens tend to be more organic. Okay. But like when you look at it that way, the allergens tend to be more organic. So the allergens are usually different from the environmental factors, like if there's a weather change, the weather gets cold all of a sudden, that is not an allergen. It's a trigger factor, but it's not an allergen.
Then when do we diagnose asthma in children? Because I remember some time ago, we had a child who it's clearly asthma. The prescriber also said it's asthma, but at this age, you cannot diagnose asthma. So when do we diagnose asthma in children?
All right, okay. So you, apart from the fact that you have bronchial asthma, which means that the airway becomes narrow and all that, and you have a rhonchi, you can also have another condition called bronchiolitis. And this is beyond the bronchus. So after the bronchus, you're going to the bronchioles. So you can have an inflammation of the bronchioles, and it's called bronchiolitis. And that is common in children, especially infants. Okay. So sometimes we are not in a haste to say this is asthma, especially when you are handling a child who is less than 1 year. And I'm sure the prescriber said that's the reason why prescribers, whoever saw, said that, okay, we can't diagnose asthma in this age because it could be a bronchiolitis. Okay. It could be a bronchiolitis. And usually under 1, that is what you tend to find. It's more of a bronchiolitis. From 2 to 3, if you have something like a rhonchi in the chest, it's not likely to be a bronchiolitis. And especially if there's a family history, then you say that it's asthma. So the reason there is because of the fact that you could have a bronchiolitis in a child who is less than 1, and that's one of the commonest things that they get. Okay.
Good morning.
Yeah, good morning.
Actually, are you done with the question?
No, please. If you allow me some few minutes, please.
Okay.
So please, sometimes, as you are aware, you go to the facility or on the practice, you combine some things to do things, and for example, in the oxygen and then the nebulizer. Sometimes instead of connecting the nebulizing chamber to the nebulizer, we connect it to the oxygen cylinder. So it's like you are giving the oxygen and then the nebulizer at the same time. Is it a good practice?
All right, okay. So so I see people do that. I see people try to give oxygen in addition to the agents they are giving.
Yeah.
For me, I'd rather prefer to nebulize without it. And then after the airway is opened, I'll put the patient on that. Because if you have airway restrictiveness, you are giving oxygen and the bronchodilator agent at the same time, you do not even have the effective oxygen going in at that point, because it's like it's blocked, and the bronchodilator is now going to work to open for the oxygen to get in. That's one. Sometimes when your mask is also not tightly fit, okay, and you are giving and you are mixing it with oxygen, you are going to dilute it and you are going to have your bronchodilator effect coming out from those parts that are not fit, because once you are giving with oxygen, the pressure is more, right? So you are going to have the agents leaking out more. So you won't have that bronchodilator effect that you want. And as I say, at that point, what the patient needs is oxygen, you are right. But the reason why the patient is not getting the oxygen is not because there's no oxygen in the environment. There's oxygen, but there's something preventing the oxygen from getting down there. So get rid of what is preventing the oxygen, and the oxygen will get down there.
Okay. All right, thank you. The last one. What is the typical thing would you see on chest X-ray of asthmatic patients?
All right, okay. So you could have an asthmatic patient who comes to you, the chest X-ray will be fine. Okay. But if you have the asthma, if you have a child with asthma and the child has not experienced persistent or repeated attacks, the chest X-ray might be fine. But then one of the classic things you see is that you realize that the chest is sort of expanded because of that kind of difficulty in breathing. The chest tends to be expanded. When you take the chest X-ray and you compare it to somebody who doesn't have asthma, you would see that kind of difference. Okay. So it's just an inflation of, the word is inflation, overinflation of the lungs.
Okay.
So it's one of the common things that you find. But I mean, you check and then you realize that, okay, not everybody has that. But once you have repeated asthma, then you are going to have what we call pulmonary hyperinflation. Okay. All right.
Thank you, sir.
You're welcome. Yes.
Sir,
yes,
can you
please.
kindly go over the management again with the drugs? It seems
all right. Okay. Okay. So what you are doing is the drugs. Always remember 3 main drugs. The salbutamol, which is a beta-2 agonist. Okay. Then your ipratropium bromide. Okay. And then hydrocortisone. These are the 3 main drugs that we use. Okay. When your patient comes to you, what you are doing is that you want to open the airways. So you are giving the muscles cause like bronchodilation. That's one. You just basically want to relax the smooth muscle. Okay. And that is why you are giving your salbutamol. Your salbutamol has that effect. So as soon as the patient comes to you, we are going to give your salbutamol or Ventolin. Okay. And as I said, you are going to give 3 doses within 1 hour, 30 minutes, meaning you are giving 3 doses 30 minutes apart. So if you start nebulizing the patient and then in 10 minutes, your first nebulization is gone, okay, you have to wait for 20 minutes and listen to the chest and nebulize again. You get it? So you have to listen to the chest and then nebulize again. So you are nebulizing every 30 minutes, basically, 3 doses. And whilst you are nebulizing, your line is in there, you are giving your hydrocort, because the hydrocort is an anti-inflammatory drug. And we said all that asthma does is inflammation. We want to get rid of the inflammation. So we give you the hydrocort to sort out the inflammation. Sometimes, however, the bronchodilation will fail to happen only on your salbutamol. So you give another drug which also causes bronchodilation, but through another mechanism. And that's where your ipratropium bromide comes in. Your ipratropium bromide is what we call an anticholinergic drug. Okay, it acts on your muscarinic receptors, so it's anticholinergic. If you remember the pharmacology and all that, cholinergic means that you usually get bronchoconstriction, increased secretion. How should I even put it? There's a term, there's an abbreviation we call dumbbells. Okay, DUMBELLS. I don't know if you guys saw that during your physiology and
don't worry. I'm
pharmacology.
not doing pharmacology. I'm not doing pharmacology. We just started. So
okay.
Catch up.
So all right, great. So your dumbbells there means diarrhea, urination, meiosis, meaning that it has to do with the eye. Okay, so your pupils would basically become smaller, so that's meiosis. Okay, and then bronchoconstriction, and then emesis or vomiting, then lacrimation and salivation. That is dumbbells. These are the features you see when you have a cholinergic reaction, or when the cholinergic part of your body is functioning. You have excess secretion, so diarrhea, urination, lacrimation, vomiting, and all that. So the abbreviation is dumbbells, so you don't forget. When we meet in class, remind me to write it on the board. So any drug that has an anticholinergic activity will give you the opposite of dumbbells. So instead of diarrhea, an anticholinergic drug will give you the opposite of diarrhea. Instead of meiosis, it will give you mydrosis, meaning that it would open your pupil so that you can see well. Okay. Instead of bronchoconstriction, it will give you bronchodilation. So ipratropium is an anti-cholinergic drug, which would act on your muscarinic receptors. And in this way, it would cause what? Bronchodilation. Whereas your salbutamol acts on your beta-2 agonist to cause bronchodilation. So you are going to cause bronchodilation using two different mechanisms. So it would work and it will open the airway for you. Once it opens the airway for you, you are going to have air getting there and the asthma is sorted. Okay, so firstly, salbutamol hydrocot. If it fails to work, ipratropium. Okay, if it fails to work, then that's where the aminophylline comes in. The aminophylline will also cause what we call a bronchodilation through a very, very funny mechanism. But basically, we need calcium for muscle contraction, right? So the aminophylline would work through some connection where you have something we call cyclic AMP not being able to work and all that. And then calcium won't get into the cell, so the cell will fail to contract. Then you're going to have a bronchodilation. So it's all about bronchodilation. All these three drugs work to cause bronchodilation. Salbutamol on the beta-2 agonist, ipratropium on the muscarinic receptors to cause anticholinergic effect, and aminophylline, basically inhibition of what we call phosphodiesterase inhibitor. It works on that, and then you don't get calcium into the cells, so no contraction. Hence, you have what? Bronchodilation. Okay, so that's how it works. But I'm saying that you do that in the acute state. But when you are discharging your patient, you discharge your patient on a steroid and an inhaler. So you give the patient a preventer and then a reliever. The patient will only use the reliever when he has an asthmatic attack. And the reliever, the commonest one we know is Ventolin, which contains salbutamol. You ask them to take 2 puffs whenever they have an asthmatic attack. But you can't have a patient who is always, every single day, he uses the reliever. That is a sign of uncontrolled asthma. So you rather put the patient on a preventer and you tell the patient that, okay, use this morning and evening. It will prevent you from getting an asthmatic attack. But in any case where an asthmatic attack starts, just take the reliever and use and come to the hospital. Are we okay? Okay. And then with the antibiotics, I said that your target is gram-positives and atypical organisms because they usually cause upper respiratory tract infections. Okay. So in general, respiratory tract infection. So you give something to cover for gram-positives, and the penicillins are the common ones. So amoxicillin, if you find yourself in a local place, but if you are in the city, it's always good to write your amoxiclav. Okay, so amoxiclav and then azithromycin for your patient to take care of gram-positives and atypicals.
Okay, okay, sir.
Yeah.
So please, I have a question.
Sometimes, yeah, okay, one more thing. Sometimes you also put a patient on a cough syrup, depending on what you think. So there are some cough syrups which contain salbutamol, something like Viscof S. So you can put the patient on something like that if the patient has asthma and has a cough as well. All right, please let your question come.
Okay, so with the precipitation factors, you mentioned the drugs, the beta blockers and then the NSAIDs. So with the NSAIDs, just like we have the beta blockers that having some receptor selective activity, the NSAIDs to have the COX-1 and the COX-2. So in this case, if you are using the COX-2 selective, is it possible going to affect the and contribute to the broncho?
To it. Okay, so the COX-2 would avoid that pathway. Okay, so the ones that will block the COX-2 would avoid that pathway. So it means your COX-1 will still go through the process and produce your prostaglandins for you. So that one is of an advantage when you give a selective COX inhibitor. That one is of an advantage than just giving a non-selective one.
Okay, thank you, sir.
You're welcome. Okay. Yeah. Nick, please, what time is your next class?
It's been moved ahead, so I think we can do the pneumonia as well. We can.
All right. Okay, great.
One last question.
Yes, please.
Does asthma trigger hypertension?
Okay, so it's a good question. As a compensatory mechanism, when you start having difficulty in breathing, okay, your body senses a lack of oxygenation. Okay, once your body senses a lack of oxygenation, it feels, okay, blood is not getting to certain parts of the body. So in so doing, there's a compensatory mechanism to increase blood supply to tissues. But the thing is that your blood, it's not like your blood is not getting into the tissues. Blood is getting into the tissues, all right, but then there's lack of oxygen in the blood getting into the tissues. So when the compensatory mechanisms come in to increase blood supply to the tissue, your BP will go up. Part of the compensatory mechanism is your heart rate going up. And remember, we said cardiac output is stroke volume times heart rate. Okay, so when you have asthma as a compensatory mechanism to enable tissue perfusion, cardiac output will go up because heart rate will go up, and that will affect your blood pressure. Your systolic blood pressure will go up. So it's one of the common things we see. Asthmatic patients will come to you with very, very antihypertensive. As soon as you nebulize the patient will be fine. I don't know if I've told you about the case I saw at Tema General where BP was so high in a young patient with asthma, and the caregiver gave hydralazine 50 milligrams, all because he felt the BP was high, and we lost the patient. So yes,
we
you'd have.
Sir, it's less than a minute. It may time out anytime soon.
All right. Okay.
Yes.
So we'll have to drop it and start with the pneumonia. But are you okay